Manic and hypomanic disorders. The distinction is based on whether the person has ever experienced a full-blown manic episode. Mania typically begins abruptly. The hallmark feature of a manic episode is increased activity or energy. During a manic episode, the person experiences a sudden elevation or expansion of mood and feels unusually cheerful, euphoric, or optimistic. Symptoms last for 1 week or require hospitalization. Symptoms cause significant distress or functional impairment. Hypomania, characterized by less severe symptoms of mania. Symptoms last at least 4 days. Clear changes in functioning that are observable to others, but impairment is not marked. No psychotic symptoms are present. Cyclothymic disorder usually begins in late adolescence or early adulthood and persists for years. During a period of at least 2 years, the adult with cyclothymia has numerous periods of hypomanic symptoms that are not severe enough to meet the criteria for a hypomanic episode and numerous periods of mild depressive symptoms that do not measure up to a major depressive disorder major depressive episode. Rapid cycling specifier. Presence of at least 4 manic or depressive episodes within a year. When this direct transition from one mood state to another happens, it is referred to as rapid switching or rapid mood switching. Epidemiology and consequences. Prevalence rates lower than MDD, 1% for bipolar, Westman et al. 1996. The average age of onset for bipolar 1 disorder is from 15 to 18 years old and for bipolar 2 disorder from 19 and 22, although cases of both can begin in childhood, no gender differences. Tends to be recurrent, severe mental illness, a third unemployed a year after hospitalization, Harrow et al. 1990, suicide rates high, Angst et al. 2002. Neurotransmitters MDD, low levels of norepinephrine, dopamine, and serotonin. Mania, high levels of norepinephrine and dopamine, low levels of serotonin. However, medication alters levels immediately, yet relief takes 2 to 3 weeks. New models focus on sensitivity of postsynaptic receptors, depleting tryptophan, a precursor of serotonin, causes depressive symptoms in individuals with personal or family history of depression. Individuals who are vulnerable to depression may have less sensitive serotonin receptors. Sobczak et al. 2002. Neurobiological factors, depression, brain imaging, structural studies focus on number of or connections among cells. Functional activation studies focus on activity cells. Key brain structures involved in MDD. Feeling of disappointment and depression has been linked to the hyperactivity in lateral habenula. People who'd experienced depression had hyperconnectivity in areas of the brain which have been associated with rumination. Jacobs et al. 2014. Neurobiological factors or mania. Overactivity of the neurotransmitter norepinephrine could be related to mania. Research has found that mania-like depression may be linked to low serotonin activity. Neuroendocrine system. Overactivity of HPA axis triggers release of cortisol, stress hormone. Findings that link depression to high cortisol levels. Cushing syndrome causes oversecretion of cortisol. Symptoms include dose of depression. Injecting cortisol in animals produce depressive symptoms. Social factors, life events, prospective research. 42 to 67% report a stressful life event in year prior to depression onset. Given example, romantic breakup, loss of job, death of loved one. Replicated in 12 studies across 6 countries. Brown and Harris, 1989. Lack of social support may be one reason as stressors triggers depression. Interpersonal difficulties, high levels of expressed emotion by family member predicts relapse. Marital conflict also predicts depression. Behavior of depressed people often leads to rejection by others. Excessive reassurance seeking, few positive facial expressions, negative self-disclosures, slow speech, and long silences. Psychodynamics, depression, loss of loved person, object, perceived as rejection, self-hatred, rigid superego, serves to punish oneself, caused by anger, converted into self-hatred. Mania, viewed as defense against underlying depression, feelings of worthlessness are converted by means of denial, reaction formation, and projection to grandiose delusions. Emotional factors affect high negative effect, low positive effect. In response to positive stimuli, or stimuli, depressed individuals experience fewer positive facial expressions, report less pleasant emotion, show less motivation, demonstrate less psychophysiological activity. Personality factors, neuroticism, tendency to react with high levels of negative affect. Predicts onset of depression, Jorm et al. 2000, extroversion associated with high levels of positive affect. Low extroversion does not always precede depression. Inadequacy. If the child has overbearing, critical, and authoritarian parents, it is likely that whatever the child will never be enough to please the parent. Anger. Those who suppressed their anger has a greater tendency for depression. Dependency on others, low self-esteem, cognitive view depression, Beck's theory, negative triad, negative view of self-world future, negative schemata, underlying tendency to see the world negatively, negative schemata cause cognitive biases, tendency to process information in negative ways. Mania, individual denies certain aspects of reality in order to promote or preserve an unrealistic set of self-perceptions, a superficial one that serves to cover up underlying depressed thinking. Psychological treatment of mood disorders. Interpersonal psychotherapy or IPT. Short-term psychodynamic therapy focus on current relationships. Cognitive therapy. Monitor and identify automatic thoughts. Replace negative thoughts with more neutral or positive thoughts. Behavioral activation. Increase participation in positively reinforcing activities, mindfulness-based cognitive therapy, MBCT, strategies including meditation to prevent relapse, treatment for bipolar disorders. Psychoeducational approaches typically help people learn about the symptoms of the disorder, the expected time course of symptoms, the biological and psychological triggers for symptoms, and treatment strategies. Suicide. Key terms in the study of suicidality. Suicide ideation, thoughts of killing oneself. Suicide attempt, behavior intended to kill oneself. Suicide, death from deliberate self-injury. Non-suicidal self-injury, behaviors intended to injure oneself without intent to kill oneself. Epidemiology of suicide and suicide attempts. Worldwide, about 9% of people report suicidal ideation at least once in their lives, and 2.5% have made at least one suicide attempt. Men are 4 times more likely than women to kill themselves. Women are more likely than men are to make suicide attempts that do not result in death. Etiology of suicide. Psychodynamic model views depression as the turning inward of anger against the internal representation of a lost loved object. Suicide then represents inward directed anger that turns murderers, may be motivated by the death instinct. Existential and humanistic theory relates suicide to the perception that life has become meaningless, empty, and essentially hopeless. Sociocultural theory, people who experience ennui, who feel lost, without identity, rootless, are more likely to commit suicide. Alienation may play a role in suicide. Learning theory, lack of problem-solving skills for handling significant life stress. Social cognitive theory may be motivated by personal expectancies such as beliefs that one will be missed by others, or that survivors will feel guilty for having mistreated a person, or that suicide will solve one's own problems or even other people's problems. Potential modeling effects of observing suicidal behavior in others. Biological factors, genetic factors, genes that affect the regulation of serotonin in the brain are also implicated in suicide. Neurotransmitter imbalances, lowered serotonin activity leads to disinhibition or release of impulsive behavior that takes the form of a suicidal act in vulnerable individuals. Myths about suicide. Myth. People who threaten suicide are only seeking attention. Fact. Not so. Researchers report that most people who commit suicide give prior indications of their intentions or consulted a health provider beforehand. Luma Marthim in Person, 2002. Myth. A person must be insane to attempt suicide. Fact. Most people who attempt suicide may feel hopeless, but they are not insane. In other words, out of touch with reality. Myth. Talking about suicide with a depressed person may prompt the person to attempt it. Fact. An open discussion of suicide with a depressed person does not prompt the person to attempt it. In fact, extracting a promise that the person will not attempt suicide before calling or visiting a mental health worker may well prevent a suicide. Myth. People who attempt suicide and fail aren't serious about killing themselves. Fact. Most people who commit suicide have made previous unsuccessful attempts. Myth. If someone threatens suicide, it is best to ignore it so as not to encourage repeated threats. Fact. Although some people do manipulate others by making idle threats, it is prudent to treat every suicide threat as genuine and to take appropriate action. Source: adapted from Nevid J.S. 2013. Psychology. Concepts and Applications, 4th edition, Belmont, California. See Engage Learning, reprinted by permission. Schizophrenia. One of the psychotic disorders: thought, emotion, behavior, disordered thinking, faulty perception and attention, disturbances in movement or behavior, disrupted interpersonal relationships. Generally comprises of two general symptoms: positive symptoms, presence of inappropriate symptoms; negative symptoms, absence of appropriate ones. Disorganized symptoms, movement symptoms. Positive symptoms, delusion, beliefs contrary to reality and firmly held in spite of disconfirming evidence. A person may believe that thoughts that are not his or her own have been placed in his or her mind by an external source. This is called thought insertion. A person may believe that his or her thoughts are broadcast or transmitted so that others know what he or she is thinking. This is called thought broadcasting. A person may have grandiose delusions, an exaggerated sense of his or her own importance, power, knowledge, or identity. A person may have ideas of reference incorporating unimportant events within a delusional framework and reading personal significance into the trivial activities of others. Motivational view would look at these beliefs as attempts to deal with and relieve anxiety and stress. Deficit view sees these beliefs as resulting from brain dysfunction that creates disordered cognitions or perceptions. Hallucinations. The experience of sensory events without any input from the surrounding environment, often auditory than visual. They believe voices are coming from somewhere or somewhere else, but it is probably their own thoughts they are hearing. Negative symptoms, avolition, refers to a lack of motivation and the seeming absence of interest in or an inability to persist in what are usually routine activities. Asociality, severe impairments in social relationships. Anhedonia, a loss of interest in or a reported lessening of the experience of pleasure. Affective flattening refers to a lack of outward expression of emotion. Alogia refers to a significant reduction in the amount of speech. Disorganized symptoms. Disorganized speech refers to problems in organizing ideas and in speaking so that a listener can understand. Loose associations or derailment, in which case the person may be more successful in communicating with the listener but has difficulty sticking to one topic. Tangentiality, that is, going off on a tangent instead of answering a specific question. Disorganized behavior, people with the symptom may go into inexplicable bouts of agitation, dress in unusual clothes, act in a childlike or silly manner, hoard food, or collect garbage. Movement symptoms. Abnormal psychomotor behavior refers to disturbances in movement behavior. Catatonia is the prime example of this symptom. Schizophrenia spectrum and other psychotic disorder. Two brief psychotic disorders are schizophreniform disorder and brief psychotic disorder. The symptoms of schizophreniform disorder are the same as those of schizophrenia but last only from 1 to 6 months. Brief psychotic disorder lasts from 1 day to 1 month and is often brought on by extreme stress such as bereavement. Schizoaffective disorder comprises a mixture of symptoms of schizophrenia and mood disorders. Delusional disorder is troubled by persistent delusions of persecution or by delusional jealousy. Attenuated psychosis syndrome, less severe presentation of delusions, hallucinations, or disorganized speech in past month, occurring at least once per week. Etiology of schizophrenia. Evaluation of genetic research. Genetics doesn't completely explain disorder. Diathesis stress model. Genetic factors constitute underlying predisposition. Stress triggers onset. Neurotransmitters, dopamine theory, increased limbic dopamine activity, positive symptoms, decreased frontal dopamine activity, negative symptoms, dopamine abnormalities, mainly related to positive symptoms, norepinephrine theory, increased level of norepinephrine levels, GABA hypothesis, decreased GABA activity, serotonin hypothesis. Both hyperserotonemia and hyposerotonemia are reported among schizophrenia patients. Glutamate hypothesis, hypofunction of the glutamate. Neurodevelopmental hypothesis, abnormal neuronal migration during the second trimester of fetal development. Etiology of schizophrenia, brain structure and function. Enlarged ventricles implies loss of cells, correlate with poor performance on cognitive tests, poor premorbid adjustment, poor response to treatment, reduced activity in prefrontal cortex involved in speech, executive functions, goal-directed behavior may be related to dopamine underactivity, brain structure and function, prefrontal cortex, many behaviors disrupted by schizophrenia, given examples, speech, decision-making, are governed by prefrontal cortex, show impairments on neuropsychological tests of prefrontal cortex, show low metabolic rates in prefrontal cortex. Another part of the brain that seems to be most active during hallucinations was Broca's area. These observations support the metacognition theory that people who are hallucinating are not hearing the voices of others but are listening to their own thoughts or their own voices and cannot recognize the difference. Allen and Modinos, 2012. Psychodynamics. Result of the disintegration of the ego. According to the Freudians, some types of abnormal upbringing, particularly if there is a cold, rejecting schizophrenic mother, can result in a weak and fragile ego whose ability to contain the ID's desires is limited. Three major primitive defenses interfere their reality testing: delusional projection, frank delusions about external reality, psychotic denial, rejection of reality and facts that are already verified, psychotic reaction formation, turning a disturbing idea or impulsive into its opposite, psychotic distortion, gross impairment in perceiving reality differently than others. Etiology of schizophrenia, psychological factors. Reaction to stress, more reactive to stress, greater decreases in positive mood and increases in negative mood. Socioeconomic status, higher rates among poor, Genic hypothesis, stress of poverty causes disorder, social selection theory, downward drift of SES. Family factors, schizophrenic mother, cold, domineering, conflict-inducing, no support to this theory. Communication deviance, hostility and poor communication. Family CD, predicted onset in one longitudinal study. CD not specific to families of schizophrenic patients. Family and relapse. The environment to which people with schizophrenia are discharged has great bearing on how soon they are rehospitalized. Study of expressed emotions, EE. Three characteristics: critical comments, hostility, and emotional over-involvement. 10% of the patients returning to low EE homes had relapse, but 58% of the patients returning to high EE homes had gone back to the hospital. Developmental studies, developmental histories of children who later develop schizophrenia, lower IQ, more often delinquent and withdrawn, coding of home movies, poorer motor skills, more expression of negative emotion, treatment, medications, use of antipsychotic drugs or aka neuroleptics, psychological treatment, social skills training designed to teach people with schizophrenia how to successfully manage a wide variety of interpersonal situations, family therapies, education about schizophrenia, information about antipsychotic medication, blame avoidance and reduction. communication and problem-solving skills within the family, social network expansion, hope. Cognitive behavior therapy. People with schizophrenia can be encouraged to test out their delusional beliefs in much the same way as people without schizophrenia do. CBT in schizophrenia suggests that this treatment, along with medication, can help reduce hallucinations and delusions. Psychoeducation, an approach that seeks to educate people about their illness, including the symptoms of the disorder, the expected time course of symptoms, the biological and psychological triggers for symptoms, and treatment strategies. Disorders of childhood, classification and diagnosis of childhood disorders, developmental psychopathology, studies disorders with context of normal child development, externalizing disorders characterized by outward behaviors, non-compliance, aggressiveness, overactivity, impulsiveness, includes attention deficit hyperactivity disorder, conduct disorder, and oppositional defiant disorder, more common in boys. Internalizing disorders characterized by inward behaviors, depression, anxiety, social withdrawal, includes childhood anxiety and mood disorders, more common in girls. Attention deficit hyperactivity disorder. Excessive levels of activity, fidgeting, squirming, running around when inappropriate, incessant talking, distractibility and difficulty concentrating, makes careless mistakes, can follow instructions, forgetful, must be severe and persistent, present for at least 6 months and cause impairments in functioning. Congress created National ADHD Awareness Day, first observed September 7, 2004. 3 subcategories in DSM- IV-TR, predominantly inattentive type, predominantly hyperactive impulsive type, combined type. Differential diagnosis: ADHD or conduct disorder. ADHD, more of task behavior, cognitive and achievement deficits. Conduct disorder, more aggressive, act out in most settings, antisocial parents, family hostility. ADHD often comorbid with anxiety and depression. Prevalence estimates 2 to 7% worldwide. More common in boys and girls. Maybe because boys' behavior more likely to be aggressive. Symptoms persist beyond childhood. Numerous longitudinal studies show 65 to 80% still exhibit symptoms. 60% of adults continue to meet criteria for ADHD in remission. Girls with attention deficit hyperactivity disorder, Hinshaw et al. 2006, large ethnically diverse study of girls combined type had more disruptive behaviors than inattentive type, more comorbid diagnosis of conduct disorder or oppositional defiant disorder than girls without ADHD, viewed more negatively by peers than inattentive type of girls without ADHD. Inattentive type viewed more negatively by peers than girls without ADHD. Girls with ADHD more likely to be anxious and depressed, exhibit neurological deficits, give an example, poor planning, problem solving, have symptoms of eating disorder, and substance abuse by adolescents. Etiology of ADHD, genetic factors, adoption and twin studies, heritability estimates as high as 70 to 80%, 2 dopamine genes implicated, DRD4, dopamine receptor gene, DAT1, dopamine transporter gene. Mixed support for this gene, either gene associated with increased risk only when prenatal maternal nicotine or alcohol use are present. Neurobiological factors, dopaminergic areas, smaller in children with the ADHD, frontal lobes, caudate nucleus, globus pallidus, poor performance on tests of frontal lobe function. Perinatal and prenatal factors, low birth weight, can be mitigated by later maternal warmth, maternal tobacco and alcohol use. Environmental toxins, limited evidence that food additives can have a small impact on hyperactive behavior. No evidence that refined sugar causes ADHD. Nicotine from maternal smoking. Exposure to tobacco in utero associated with ADHD symptoms may damage dopaminergic system, resulting in behavioral disinhibition. Parent-child relationship. Parents give more commands and have more negative interactions. Family factors interact with genetic and neurobiological factors, contribute to or maintain ADHD behaviors but do not cause them. Treatment of ADHD. Stimulant medications, Ritalin, Adderall, Concerta, Strattera, reduce disruptive behavior, improve interactions with parents, teachers, peers. improve goal-directed behavior and concentration, reduce aggression, side effects, loss of appetite, weight, sleep problems. Medication plus behavioral treatment, MTA study, slightly better than meds alone. Improve social skills, whereas meds alone did not know difference in groups at 3-year follow-up. Stimulant medication, more effective for some children than others. Psychological treatment, parental training, change in classroom management, behavior monitoring and reinforcement of appropriate behavior, supportive classroom structure, brief assignments, immediate feedback, task focused style, breaks for exercise, conduct disorder, CD, pattern of engaging in behaviors that violate social norms, the rights of others and are often illegal, aggression, cruelty towards other people or animals. Lying, stealing, vandalism, often accompanied by lack of remorse and callousness, frequent and severe offenses. Oppositional defiant disorder, ODD. ODD behaviors do not meet criteria for CD, but child displays pattern of defiant behavior, argumentative, loses temper, lack of compliance, deliberately aggravates others, hostile, vindictive, spiteful, or touchy, blames others for their problems, comorbid with ADHD, learning and communication disorders, disruptive behavior of ODD, more deliberate than ADHD, most often diagnosed in boys but may be as prevalent in girls, conduct disorder, CD behavior impacts others, many times first identified by criminal justice system. Substance abuse common, unclear whether it precedes or is concomitant with disorder. Comorbid with anxiety and depression. Comorbidity rates vary from 15 to 45%. CD precedes anxiety and depression. Prevalence, boys 4 to 16%, girls 1.2 to 9%. Etiology of conduct disorder, genetic factors, heritability likely plays a part. Twin study data show mixed results. Adoption studies focus on criminal behavior, not conducted disorder. Meta-analysis of twin and adoption studies suggest 40 to 50% of antisocial behavior is heritable. Genetic, a stronger influence when behaviors begin in childhood rather than adolescence. Genetics and environment interact. Caspi et al. 2002. Abuse as a child plus low MAOA activity most likely to develop CD. Neurobiological factors. Poor verbal skills, difficulty with executive functioning, low IQ, lower levels of resting skin conductance and HR. Psychological factors, deficient moral development, especially lack of remorse, modeling and reinforcement of aggressive behavior, harsh and inconsistent parenting. Lack of parental monitoring, cognitive bias, cannot dodge, neutral acts by others perceived as hostile, peer influence, acceptance or rejection by peers, affiliation with deviant peers, sociocultural factors, poverty, urban environment, higher rates of delinquent acts among African American males linked to living in poorer neighborhoods rather than race, Peoples and Lober, 1994. Treatment of conduct disorder, family interventions, family checkups, FCU, associated with less disruptive behavior, parental management train, PMT, Gerald Patterson, teach parents to reward pro-social behavior, cognitive therapy, anger control training, depression in children and adolescents, symptoms common to children, adolescents and adults, depressed mood, inability to experience pleasure, fatigue, problems concentrating, suicidal ideation, symptoms specific to children and adolescents, higher rates of suicide attempts and guilt, lower rates of early morning awakening, early morning depression, loss of appetite, weight loss, depression, and anxiety in children and adolescents. Commonly co-occur with ADHD and CD, also co-occur with each other. Early research suggested that depression and anxiety could be distinguished from one another in the same way they are in adults. Depression, high negative effect, low positive effect. Anxiety, high negative effect, but not low levels of positive effect. More recent research calls this finding into question. Depression in children and adolescents. Depression recurrent. Prevalence 1% of preschoolers, 2 to 3% of school-age children. Adolescent rates equivalent to adult levels. Girls 7 to 13%, twice that or of boys. No difference in symptoms experienced. Etiology of depression in children and adolescents. Genetic factors, early adversity and negative life events, family and relationship factors, a parent who is depressed, parental rejection only modestly associated with depression, children with depression and their parents interact in negative ways, less warmth, more hostility, cognitive distortions and negative attributional style, stable attributional style, Cole et al. 2008, develops by early adolescence by middle school attributional style, serves as a cognitive diathesis for depression, treatment of depression in children and adolescents, medications SSRIs more effective than tricyclics, meta-analysis showed medications most effective for anxiety other than OCD, less effective for depression and OCD. Concerns about medication, side effects including diarrhea, nausea, sleep problems, and agitation, possibility of increased risk of suicide attempts. CBT, more effective for Caucasian adolescents, those with pre-treatment good coping skills and recurrent depression. Interpersonal psychotherapy, IPT, focuses on peer pressures, transition to adulthood, and issues related to independence. Psychotherapy generally only modestly effective with children and adolescents. CBT no better than non-CBT therapies.